Hey guys, let's just wanted to get a week block to wrap up out to you. Overall, there's been really good engagement on the boards. We need you to keep that up. There's been a few groups that have a lag behind in this, but for the most part, we're doing a really good job. Just be sure to get your response posts in early during the week, and then come back and check on them each day. This is really where the bulk of learning happens for these management courses. So be sure not to cheat yourself or your group mates there. Um, Continue to bring in some outside resources and articles for us to discuss. Share those on Dropbox. We're doing generally a pretty good job of that. So just keep that up. This week we discussed proximal hamstring strains. And we really need to make sure that we're doing a good differential diagnosis here and trying to implicate the primary driver of those symptoms, whether that is the proximal hamstring, but making sure that we're assessing for neurodynamics and ruling out the lumbar spine. And for lumbar spine, we really need to be doing overpressure of those active movements. And because of the weight that we will add to the hip joint itself, we probably need to do some prone accessory testing and CPAs and UPAs to fully rule that structure out. And then as we've ruled in proximal hamstring or a hamstring pathology, making sure that we're training the muscle appropriately and really progressing all the way to eccentrics. And then we'd like to use our test, treat, retest method here with proximal hamstring strains. And so maybe that includes getting out your inclinometer and using a straight leg raise, especially early on when those symptoms are a bit more irritable. That may be a good way to test, treat, retest. We also talked about hip OA this week, and the Hando trial was a really good one that gave us a lot of insight into clinical reasoning. And we need to be using manual techniques to treat this, but also exercise. And exercise compliance is highly associated with that long-term maintenance of that progress that we've gotten during our plan of care. We also saw in the Hando trial the clinical reasoning that Hando used to help guide those interventions. And that is simply following your subjective asterisk sign. Maybe that's hip flexion or donning socks that the patient complains that they have difficulty doing. And that is associated with hip flexion seen in the objective exam. And we can easily measure that and what was their pain rating upon doing that. And then maybe we match our treatment to that in doing a long axis distraction manipulation or a caudal glide, and then we come back and retest that hip flexion, and then going back out to subjective, we're very sure to ask them on the next visit, how was donning your socks after last visit? Okay, and then finally we talked about a bit about FAI. Diagnosis here, there is a fair amount of FAI in folks who are asymptomatic. So this doesn't necessarily mean that, again, our imaging falls short in predicting who is going to have symptoms. And the medical community is very surgery happy for these folks, so which may or may not be completely appropriate. But let's do our best to keep them out of the operating room. So just don't get caught up too much in the diagnosis of FAI, but just break that down into your impairments. Okay, the patient has decreased hip flexion and decreased hip internal rotation, and then treat that as such, matching manual interventions to that. As far as prognosis, FAI, when treated conservatively, we do know that doesn't predict future hip OA to a greater degree in those who have FAI and those who don't. So letting this go may not necessarily be a horrible thing. Okay, then finally for next block, we are talking about knee disorders. If you have any questions about anything we've talked about so far, be sure to reach out to me. and you will be getting some midterm feedback, qualitative midterm feedback from myself and your TAs. So we'll see you on the discussion boards for Block 3.